That eye is bleeding. That is an eye problem. Call the eye doctor. What do you mean it's not that bad and there's a simple solution? All right, I'll listen to the case and I'll be sure to watch to the end. Isn't that what I'm supposed to do? Like, keep watching to the end. All right. A 65-year-old female presents to an urgent care with a bloodshot left eye. The patient stated that she woke up this morning about 2 hours ago and was in her bathroom getting ready for the day and was shocked by what she saw in the mirror. Alarmed, she and her wife quickly grabbed their things and went to the nearest urgent care. This has never happened before, and she first noticed this morning. She denies recent surgery or trauma, and she tells you, "I look like I got beat up. Am I gonna go blind?" Both eyes are asymptomatic, including no eye pain, discomfort, or vision changes. And the patient tells you that had she not looked in the mirror, she wouldn't have even known there was a problem. She has a history of hypertension controlled with medication and a transient ischemic attack 3 years ago. She had uncomplicated bilateral cataract surgery 1 year ago, which she tells you she is just so happy about because now she doesn't have to wear glasses when she drives. She also reports a one-time occurrence of acute anterior uveitis of the left eye 26 years ago. For medication, she takes lisinopril for her hypertension and aspirin 81 milligrams once per day due to the prior TIA. On exam, her blood pressure is a little elevated at 143/94. The patient tells you that that's higher than normal, but she thinks she's a bit nervous. For the eye exam going right to left as routine, the right eye visual acuity is 20/20, and the pupil, eye pressure, motility, and confrontation visual fields were all within normal. And the anterior segment exam was overall unremarkable for acute findings. For the left eye, the visual acuity was also 20/20, and the pupil, eye pressure, motility, and confrontation visual fields were within normal. For the anterior segment exam, it showed a large 360 subconjunctival hemorrhage that appeared flat without chemosis and was cidal negative. The rest of the eye exam was unremarkable for acute abnormalities. You don't see obvious signs of trauma, but this is the worst subconjunctival hemorrhage you've seen. So what could have caused this? You go back to the patient's room and ask if anything out of the ordinary happened in the last 24 hours. And the patient says, "Well, we had our book club with some friends last night, and did we enjoy some nice wine and cheese? I did choke a little on the cheese, but I was fine." Her wife chimes in and says, it was not a little. You were really coughing. I was worried for a minute there." Let's go through the causes of a subconjunctival hemorrhage, and the last one may surprise you. Trauma. And this can be on a small scale like eye rubbing or a contact lens related injury, or bigger traumas like blunt or sharp ocular trauma, procedure or surgery on the eye or eyelid. Some examples include cataract, LASIK or retinal surgery, eye injections, and even eyelid surgery. Valsalva maneuvers like vigorous coughing, sneezing, vomiting, straining like if someone has constipation, weightlifting, vaginal delivery, and choking like in our patient case. Acute hemorrhagic conjunctivitis, a bleeding disorder, tumor, and interestingly, one of the most common causes is idiopathic, meaning we don't know what caused it. As an overview, in younger patients with a subconjunctival hemorrhage, it's often due to a trauma. In older patients, it's often associated with a vascular disease like hypertension or diabetes. Here's what to do if you see a patient with a new subconjunctival hemorrhage of unknown cause. Now, these are diagnosed clinically, and the main goal is to rule out an abnormal eye exam finding that may need an evaluation or treatment with an ophthalmologist, largely ocular trauma. As an overview, check what I consider to be the 5 eye vital signs: vision, pupils, pressure, motility, and confrontation visual field. If you want to learn more about how to do the confrontation visual field test, be sure to check out this video. I'll leave a link down below in the description. Of course, examine the eye, which a slit lamp is preferred, but if that's not possible or even available, then use the resources you have to do the best that you can in the immediate setting, like a pen light exam. Assess the optic nerve if possible, and consider taking a picture for the EMR. This can be really helpful if the patient comes back and now you have a comparison, as well as if you have an ophthalmologist that's on call who's able to review the picture if you have any questions or concerns, and then can help determine next steps if needed. Now, this is the key. If there's one thing you take away from this video, it's this. In a routine, non-traumatic subconjunctival hemorrhage, other than the actual hemorrhage, the eye exam should otherwise be unremarkable, including the 5 eye vital signs. Let's talk about management. A subconjunctival hemorrhage is self-limited. It's going to heal on its own, but it will likely take some time. It can take weeks. You generally have a good visual prognosis and no treatment is needed. Most of the times, they're asymptomatic, but occasionally occasionally there may be some mild discomfort, especially if there's some elevation to the conjunctiva, chemosis, for which patients can use over-the-counter, preservative-free artificial tear eye drops as needed. If a patient takes a prescription blood thinner, I generally recommend that they continue it. If they take non-prescription blood thinners like ibuprofen, then they can consider holding that. So in the acute setting, the main goals are, number one, make sure that nothing else is going on. A subconjunctival hemorrhage can be a standalone condition that's going to heal on its own, but it could also be a clue of something else going on, and that's what you want to rule out as best as possible. And number two, get the patient plugged in with an eye doctor, which I'll talk about at the end of this video. Let's get back to the case. The patient was diagnosed with the left subconjunctival hemorrhage, likely due to her choking last night. What likely contributed to the large diffuse hemorrhage was her history of hypertension, being on a blood thinner, and her age. The patient was instructed to continue her prescription aspirin due to her prior TIA, and was counseled that because she is on a blood thinner, the hemorrhage may take longer to gradually resolve, but it should gradually fade away, although the colors may change, similar to a bruise on an arm. She'll use over-the-counter lubricating eye drops as needed for any mild discomfort. She was scheduled to see an eye doctor in clinic later that day and was counseled on the return precautions, which I'll list here. She was also told to avoid using anti-redness eye drops because they won't help and may cause problems. The patient and her wife were thankful and relieved. As they were getting up to leave, the patient said, "By the way, the cheese from last night was pretty tasty. I'll drop some off. Just don't choke on it." Let's take a moment to go through some high-yield notes on subconjunctival hemorrhage. Don't worry about writing anything down. If you want a copy of these notes, go ahead and click the link that's in the description below. A subconjunctival hemorrhage is a common cause of a red eye. It's generally a benign, painless, self-limited hemorrhage under the clear conjunctiva. Think of the hemorrhage as the red frosting in a Halloween cookie, and the top cookie is the clear conjunctiva, and the bottom cookie is the white sclera. It's commonly asymptomatic and often bothers other people more than it bothers the patient. It's commonly flat and can occasionally be bullous if there's a significant bleed or if there's associated edema and a trauma, and this could lead to mild discomfort, for which the patient can use over-the-counter lubricating eye drops as needed. But many times, these hemorrhages are an incidental finding. There are many causes, including a Valsalva maneuver like straining or choking. If a patient is on a prescription blood thinner, it's recommended that they continue the prescription blood thinner, but any non-prescription blood thinners, consider holding them. Avoid anti-redness or gets the red out eye drops. They're not going to speed up the resolution. If a subconjunctival hemorrhage recurs, it's recommended that the patient follow up with an ophthalmologist and their PCP for further workup to rule out a possible secondary cause like a bleeding disorder or tumor, although this is not common. And for follow-up, in general, I do recommend that every patient with a subconjunctival hemorrhage follow up with an eye doctor. If there was no trauma, it's a small hemorrhage, and the eye exam is otherwise within normal, generally that can be in an outpatient setting with ophthalmology or optometry. But if there's a 360 or near 360 subconjunctival hemorrhage with chemosis in a trauma, consider imaging, and it's recommended to consult ophthalmology. If you don't have ophthalmology on call, you can consider starting with getting a CT orbits. Again, CT orbits without contrast with thin cuts is really important to assess for a possible globe rupture, and then call the nearest hospital that has ophthalmology coverage and discuss the case, and then go from there. If you enjoyed this case, go ahead and click that thumbs up and subscribe to the channel. I'm hoping to get to 100 subscribers. If I do, I'm gonna be too excited, but it'll help me know that this is helpful for you, and I'll try to do more cases. The level of concern changes when a patient has a 360 subconj heme with chemosis in a trauma. To find out more and why I suggested consulting ophthalmology, check out this video where I talk about how to manage these hemorrhages in a trauma. I'll see you there.